Good morning, everyone, and welcome to pre-conference workshop session 122. We are titled COVID-19 Public Policies, Lessons from Canada, India, and South Korea, organized by Hani Kim. Hani is also one of our panelists and presenters today. In fact, I'm going to introduce the panelists throughout our session this morning, but first, a couple of things we should note. Please turn off your video and microphones so we do not hear background noise in your homes. Also note that this session will be recorded in the main room. If you are so inclined, you can tweet about the event at the conference using @SciencePolicy and hashtag CSPC 2020. You will receive a short survey at the end, which will take only a moment or two to fill out. So please do that. You are urged to do that, in fact, so that the CSPC can make improvements for next time. My name is Carole MacNeil. I'm a journalist with CBC News in Toronto, the Canadian Broadcasting Corporation here in Canada. More relevant to this panel is that I've hosted a segment on COVID-19, all of its implications and impact since almost the beginning. As Canadians, we were allowed to see the situation in real time. There was very little turnaround time between the labs and observations in hospitals because our Canadian infectious disease physicians were available to the media literally morning, noon, and night to take questions from journalists like myself and also the public in general about the information, the latest information on COVID-19 as they knew it. They informed, they revealed, they updated, and yes, sometimes they criticized our public health policy. So, what did we all learn in hindsight? How will this knowledge, global knowledge, be used to help our citizens in the future? There are hard lessons for sure, and our panelists are going to address all of it today. With that in mind, let me introduce you to our first speaker in Toronto, Maureen Taylor. Maureen is a physician assistant in infectious diseases at Michael Garron Hospital. She literally works at the bedside of patients with COVID-19. Maureen graduated from the very first physician assistant program at McMaster University in 2010. She spent her first 5 years of that career in emergency medicine at Sunnybrook Hospital. But Maureen has another perspective on this as well, and that comes from her long history as a journalist with the Canadian Broadcasting Corporation, or CBC. She was a TV and radio journalist for 25 years, and during that time, she was a health reporter for the flagship program, The National, and led our coverage of the SARS outbreak. Maureen is currently on the editorial board of the Canadian Medical Association Journal. So let's begin with Maureen. Good morning, Maureen. Maureen, I think you should unmute yourself, perhaps.
Can you hear me?
Yes.
Yes. Okay, so thank you very much for that introduction, Carole. Yes, you're going to be getting a view this morning from someone who works at the bedside here in Canada. I'm not an epidemiologist, and the government never asks my opinion about how to approach this pandemic, but I'm a great armchair quarterback, so let's go. Lots of you are familiar with the highly popular hammer and the dance analogy by Thomas Pueyo for battling this pandemic coronavirus. The hammer, of course, is the lockdown, which is ideally an almost complete shelter-in-place request to all citizens. Now, in Canada, provincial and territorial governments are responsible for healthcare, so they had to bring the hammer down individually. So they did it on different dates in March, but eventually we all got there. And the federal government stepped in early with income support programs, which of course were crucial for people who could not work from home and were facing possible layoff. Schools were closed. All but essential workers stayed home. The streets of downtown Toronto with its tall skyscrapers were empty, as were streetcars and subways. But of course, the virus was already spreading through long-term care homes, especially in the provinces of Quebec and Ontario, and that's where the majority of deaths happened in our first wave. I work in a community hospital in Toronto with a small but very proactive group of infectious disease specialists. Way back in March, we sent teams of geriatricians and infection prevention and control practitioners into the neighboring nursing homes to prepare families and staff for what would be inevitable outbreaks. We shared with them the PPE that community businesses had so generously donated to our hospital. We taught the staff how to use it. Most importantly, I think our physicians called every one of the families of those residents and got them at least thinking about the tough decisions that they would have to make if their loved ones became infected. Because at that time, the mortality rate for people over 80 was 85%. Not every long-term care home had hospitals, sending them that level of expertise and support. And so to our collective shame here in Canada, but especially in Ontario and Quebec, we have one of the highest number of deaths in long-term care of all OECD countries at just more than 80%. And 96% of all deaths in Canada have been in people over 60. So after the hammer comes the dance. According to Poyou, to keep the coronavirus at bay after you've hammered it, you have 4 layers of defense. Number 1, stop as many infections as possible from coming in. Number 2, for those that make it in, minimize the people that they meet. Number 3, when they do meet people, minimize the likelihood that they will infect somebody else. And number 4, when they do infect somebody else, identify that infection quickly and neutralize it. Many countries, including Canada, applied the hammer fairly well, but we never learned how to dance. Canada's border with the United States has nominally remained closed, but flights are still arriving every day from all over the world. Travelers are supposed to quarantine for 14 days after arriving in Canada. But apart from some daily texts and the odd phone call, we don't really know if people are adhering to those rules. In Canada, though, we can point to one great success story, which is the bubble created by the Atlantic provinces, Newfoundland, PEI, New Brunswick, and Nova Scotia. By mandating that 2-week quarantine for anyone coming into those provinces, and by mandating masks almost everywhere, they continue to enjoy very low case numbers, often none at all, and schools and businesses are operating almost as normal. But leaving aside that eagle-eye view of the Canadian response to this pandemic, I'm going to focus on the province I know best, which is Ontario. We hammered well. I was impressed that our Premier cooperated very well with the federal government. We got cases in the community down. Took a little longer to do that in the nursing homes, but by the summer, even they were allowing outdoor visits for 1 or 2 family members who could produce a recent negative COVID test. Businesses reopened with distancing and masking rules. And I think we all tried to enjoy a meal or 2 on an outdoor patio with a couple of friends. But we know now that was a mirage. Yes, the virus is much less likely to be transmitted outdoors. I read this week 16 times less likely, but there were weddings indoors and there were retirement parties in offices. And I think especially younger people began to ease up on the distancing rules. So by the end of August, even before schools had reopened, cases were climbing again, especially in people ages 24 to 35. I remember calling one young father to let him know that his COVID test was positive. He'd been tested at the testing center affiliated with our hospital. This was in early September. And he and I then on the phone tried to tangle out where he had contracted the virus. And it was clear that he had been to several large gatherings. I think there was a barbecue in a park. There was also, I think it was a retirement party. They were mainly outdoors, but there was probably not exclusively outdoor contact. And even on the day that he first began to experience symptoms of COVID, he went to his in-laws for dinner with 11 other people, and they were in their 70s, and he possibly exposed them. And do you know what makes this story stand out among the hundreds that I've heard in the last 8 months? It was that this gentleman's father had died of COVID-19 at another hospital back in April. And even with that devastating experience behind him, he didn't see the danger in attending these kinds of indoor gatherings. But I can hardly blame just him, because there's lots of blame to go around in Ontario. For one thing, the communication and messaging from our government leaders and our Chief Medical Officer of Health in Ontario, who the government relies on for advice, have been tragically confusing, contradictory, and unhelpful. Our Premier cannot be relied on to coherently describe what a social bubble looks like. He said he'd be spending Thanksgiving with his immediate family, including the children who didn't live in his house. And then a few hours later, he had to go on social media and take that back. It never made any sense to the public, and me included, that it was somehow okay for me to be able to dine inside a restaurant with 100 other people, and elementary school children like my grandsons could be in a class with 30 other kids, but I couldn't have those grandchildren over at my house for dinner. More recently, the province issued a color-coded system that was to provide guidance on what types of places and social gatherings would be allowed in certain regions, depending on the level of pandemic risk. Doug Ford said he had relied on experts to create the thresholds in that system, but his own public health agency and so-called command tables quickly disavowed this. They said, we weren't consulted on this. It's clear that Mr. Ford is setting his own arbitrary recommendations that will allow businesses to stay open as long as possible. And if a few hundred seniors in long-term care die in the process, well, that's his idea of a balanced approach. I'm going to take my slides now, if we could see those. It's too late, obviously, I'm going to go to this one first. Oh, I can't switch between them. All right, so this one, yeah, there's the first one. So you don't really have to see the numbers or the other countries we're compared to. All you need to see is how from the spring we went high, then we this is a 7-day rolling average, sort of got things under control. And then like lots of other places around the world, we started to go up. This slide, by the way, is a month old, and you would just see a worse picture if you could see something more recent. And then thanks to Dr. Jennifer Kwan for these slides, by the way. She's a great resource on Twitter for daily slides. These are our hospitalizations, ICU admissions, and people on ventilators. If you look at the inset there that just looks at from August to now, you can really see how well we were doing at the beginning of August, but we've basically squandered it. So obviously too late to prevent a second wave, but I've joined a group of other healthcare professionals this week in advocating for prevention of a third wave by taking a COVID-0 approach. We want tough restrictions for 4 to 6 weeks. We would exempt regions where cases are very low, but there would have to be controls over people coming into those regions from other regions. We want non-essential workers to work from home, and if they can't, we want the federal government to support them as well as business owners. Schools we're hoping could stay open because largely, so far in Ontario, they haven't been shown to be big super spreader drivers. So I will just end by pointing out that every country that thought they could find an easy way to manage this virus has been proven wrong. And the countries that did control it, and we're going to hear about South Korea in a little bit, have used a variety of measures, some of which we might find harsh. They for sure infringe on our freedom of movement and privacy. But at the end of the day, those countries have economies that are bouncing back, and their governments are enjoying high approval ratings from the population. I'm dressed in scrubs because I'm going to work right after this. And I'm going to see how many new patients were admitted overnight with COVID, and I'm going to see who died overnight and isn't going to be there. And I'm going to talk to the patients today with all my PPE on, and they're going to ask me, because they do every day. They look scared, and they say, am I going to be all right? When can I go home? And I'm going to tell them that they are going to be all right. And in some cases, I'll be lying. Thank you very much for your time, and stay safe.
Okay. All right. I just looked frozen in the screen, so I just wanted to make sure. Maureen, thank you for that. Very Mudra at Sai University in Chennai, India. She holds a Master's of Law and a PhD from the National Law School of India University in Bangalore. Her areas of research include health law, consumer law, human rights, Recent articles from Suchithra include Delhi to Kerala state response to COVID-19 makes it clear India needs a new health policy. And she has also written about laws around work during the coronavirus. Suchithra, over to you.
Namaste. Am I audible?
Yes, you are.
Great. Thank you, because the screen is frozen, I believe. Yeah. So to begin with, what we have as a team, what we have prepared for today is to look at how, what were the immediate response as far as state of Kerala is concerned, and also India in that context. So we have divided the presentation in such a manner that we will produce what the early groundwork is, and what has been the current intense measures, and what is the way forward. To begin with, as far as the health emergency, so to start with, what were the early groundwork that Kerala state had done is, can we move on to the next slide? Yes, great, thank you. So to start with, the most important aspect is that the state of Kerala declared this as a health emergency as early as February 2020, when the first case was reported at 30th January 2020. So, and second important aspect is that Kerala declared the Kerala Epidemic Disease Ordinance 2020, passed the ordinance, in short, which gives the power to the state government to take up certain regulations, such as sealing the state borders, restricting public and private transport, inspecting and quarantining persons arriving into the state by air, rail, road, or the sea, and also prohibiting restriction the functioning of shops and commercial establishments. So, in terms of the legality behind a lockdown. And also in the same context, the ordinance or the law also provide for penalty who disobey these regulations, and with fines and such other punishments or tickets that would be raised against. So that is yet another aspect. And similarly, there were also situations of where surveillance and screening of incoming passengers. There were also important measures of the number of days that the person needs to quarantine themselves while after a travel, so on and so forth. And the most important aspect as far as the early groundwork is concerned is how the government institutions such as the State Emergency Operations Center and Office of Kerala State Disaster Management Authority went hand in hand, or had gone to provide the support for the health department, which also provides an enabling atmosphere. So that went as far as the early groundwork is concerned. On the, could we go to the next slide, please? So, what is the status currently, and what has this ground or the early work, what has it led to? The most important aspect is that as far as the current intense measures are concerned, stronger and testing and containment strategy is something that has proved best as far as state of Kerala and India is concerned. And there are also situations where first-line treatment centers are also open, even such as institutions, for example, where my friend and my colleague, Dr. Deva Prasad, is the Indian Institute of Management. A portion of that particular institute, an education institute, one of those is being allotted as a frontline treatment center. So, excuse me. I just got a message that there is some issue with the streaming. Is there an issue?
No, proceed on.
Okay, great. Thank you. So the number of testing centers and first-line treatments that are provided, that is significant. Isolating high-risk contact or on home isolation up to 28 days is also something that is significant measure that has been taken. And it is not only that the physical health of the patient is being taken into consideration, but also mental health. So for those aspects, there are certain online services that are opened right from the government service, not only for the patient, but also for the family members or for the health worker or any person that is associated, because we also have certain government officials who work as sectorial magistrates, or like the officials that would be in contact with a patient, or just to give support and so on and so forth. So it is not only that physical health, but also mental health, and that too telemedicine portals are also available. And the most important aspect is the online portals, where that is COVID Jagrata, or wherein the details of the passengers who are traveling in and out are being systematically stored in such a manner that the rules of quarantine are explained well. And there is also, we get the calls from the health officials to check the progress of the person, including whether the person is to home quarantine and so on and so forth. If there is any difficulty, then we have the first line treatments that are readily available. So this is some of the important measures. And most importantly, Kerala had also invoked Section 144 of the Criminal Procedure Code, that is, in short, which banned public gatherings and assembly more than 5 persons, which is significant when it comes to in a public place, a shop or a establishment. They make it clear that there isn't many people that are gathered around, because we understand that gatherings are the source of the spread of virus. And also in that context, mask is made compulsory, or wearing a mask is made compulsory till July 2021 through the additional regulations that are provided. So in short, what is it that has helped Kerala and India to curb the numbers or to bring down the numbers? One is basically the public trust that is involved, and public trust in the sense that how local self-government, how there is the local self-government, and also how the government officials, so the chief minister of a particular state addresses the journalist, as how our panelists had discussed, how it was available, or how the health officials or health workers are also available with regard to the media. So in terms of how transparency was made, so the chief minister is available or open for questions and understanding what were the measures taken for curbing the spread of virus. So the most significant aspect is how public trust had been developed, and how there are situations which strengthened the infrastructure. And also to remember how the structure of governance are also helped into, because local self-government or local administration, which is the grassroots level, how those systems have been strengthened. This has also played as far as a positive side. But is that Kerala and India is devoid of the issues? No, not at all. We have certain critical issues that we look at. Can we have the next slide, please? Yeah, so what we look at is that the significant aspect is that how Kerala illustrates a long-term support for local governments, which has improved the public trust and effectiveness in response, and how India's response to COVID pandemic is also linked with the understanding of the principles of public good. This is a public trust, and in terms of how there should be fragmentation of public health system. Can we have the next slide, please? So in that context, the way forward is that there is a significant need to revamp the healthcare system, both in the public and the private sector, so that there is an effective cooperation, and they complement in such a manner that the health of the needy person is taken into consideration. And there should be investment in public sector as well. The second important aspect or second challenge that we face is that lack of cadre of specialized training public health professionals. Of course, Kerala had learned these lessons because of the Nipah virus outbreak in 2018, and the two major floods that were in 2018 and 19. Of course, yes, we have learned those lessons, but we still face those challenges. And the last is about how lack of adequate infrastructure and facilities for testing of disease is yet another major constraint that we have. So in short, these are the shortcomings that we have. But of course, India and Kerala, state of Kerala, were able to bring down the numbers. I think with this, I end the presentation. Thank you for your patient hearing.
All right. Thank you very much, Suchithra. From Seattle, Hani Kim, talking about South Korea's experience. Hani is an independent researcher who has 14 years experience of post-PhD level work in research, teaching, and grant portfolio development in infectious disease prevention and control. She's also a program officer on the pneumonia team for the Bill and Melinda Gates Foundation. She completed her PhD in lab medicine and pathobiology at the University of Toronto and received her postdoctoral training at the Max Institute of Immunology in Germany and at Toronto General Hospital. Her most recent research articles look at the political origins of health inequality, specifically around South Korea. Hani is also the organizer of this panel. Good morning, Hani.
Good morning, Carole. Thank you for the introduction. And good evening to my Indian colleagues. So first of all, I'll start with a small disclaimer. So all views you're going to hear during this talk are mine alone, and they do not represent views, interests, or funded work by the Gates Foundation. So the focus of my talk in the next 8 minutes or so are really on two broad questions. First, what were some key public policies that perhaps contributed to South Korea's ability to control COVID-19 relatively successfully? And I say that very cautiously. And more importantly, what is the socio-political context that perhaps enabled those policies? I mean, since the beginning of the pandemic, I've been reading a lot of reports describing lessons learned from South Korea. And they mostly emphasize two things: the technical aspects of diagnostics, testing strategies, drive-through centers, or a little bit more vaguely termed cultural attribute. I think the most frequently heard description is the traditional Asian value to respect authority and hierarchy. While there might be some validity to these claims, from the public health standpoint, these narratives, when they're sanitized of the socio-political context, have very limited values outside Korean context. So that's where I'm going to really zero in on. And may I have my slides, please? And could I have the next slide, please? I'm not able to advance my slides. Okay. So let's start with where we are right now in Korea. This is the current epidemic status as of October 19th, which is when I was preparing these slides. And on the top right-hand corner, the total number of cases, Korea is reporting a little bit over 420 cases per million people, total of 9 deaths per million. The case fatality rate shows fewer than 2 deaths for every 100 confirmed cases. What's shown in the orange curve is the daily, let me start with the blue curve. What's shown in the blue curve is the daily confirmed cases that corresponds to the y-axis on the right. Notice that the scale is different for the two curves. And what's shown in orange is the daily suspected cases, which means the suspected cases that are tested, and that corresponds to the y-axis on the left-hand side. So what's noteworthy here is the differential between the two curves that tells you how extensive the testing is. And the last count as of yesterday's news was the daily confirmed case was a little over, I believe, 200. And they're still testing over 5,000. Next slide, please. So what were some of the policies that were introduced during the first 42 days? So broadly speaking, they center around the classic paradigm of epidemic control, which is detect, isolate, treat. So they mainly aim to, first of all, expand capabilities for testing, as you all know, and secondly, capabilities for effective clinical triage, which is crucial for allocating precious healthcare resources to the severely ill patients. So specifically on the testing front, the first case was detected on January the 20th, which is indicated as day 1. Within almost a week, the government approved a refined protocol for the molecular diagnostic assay that reduced the assay time from 24 hours to 6 hours. And since then, throughout the 30-day period, government repeatedly revised the testing criteria to really reflect in real time the evolving picture of the transmission on the ground. On the clinical triage front, as early as day 16, so almost 2 weeks after, sorry, I'm just reading I'm not able to advance my slides still, but I'll just continue anyhow. Within the first few weeks, the government set up non-health facilities that are designated to isolate or separate asymptomatic and mild cases from the severe patients so that the severely ill patients can get more healthcare. And that effort continued throughout the first 42-day period to keep on expanding the infrastructure and allocate personnel. Next slide, please. Just moving on with the context. So in terms of the size of the population, South Korean population is a little larger than Canada, not quite as double, but larger than Canada. But imagine that population packed in a land area that's about 1/100th of Canada, and that is about 1/10th. I just looked up, population of Kerala state is comparable to Canada, and of course it is a state of a much larger country. And within South Korea, that population is split across 9 provincial governments and 6 autonomous cities. Now, last but not least, before we go into the government, the healthcare setting. So like Canada, South Korea also has a single-payer universal healthcare, which is largely financed by tax and monthly contributions by the citizens. The actual provision of health services, like Canada, is done by private hospitals, not government-owned like what you would see in UK. In terms of the actual government that oversaw the current response to COVID, there is some prior lessons learned. So like many places in the world, in the last 2 decades, South Korea has experienced 3 infectious disease outbreaks. SARS in 2003, H1N1 influenza in 2009, and MERS coronavirus outbreak about 5 years ago, all under different administrations. During the last government, which oversaw the MERS outbreak, there was a huge public uproar over the government's mishandling of the outbreak response. For example, delayed testing, failure to detect and isolate the super spreaders, and most importantly, government's lack of transparency in communicating risks to the public in real time. So what you see in the right-hand side is an image of peaceful protesters that were happening across the country, which eventually led to the impeachment of the president over multiple charges, not just the MERS outbreak mishandling. Importantly, in response to such a strong public demand, the government made a concrete public investment to expand and strengthen Korean Center for Disease Control and the subnational rapid response teams. Also, the government, and this is all under the previous government, they also established a new interministerial emergency response coordinating mechanisms. In other words, they kind of set up the coordinates in place to activate in times of epidemic response. As a legislative action, the previous government introduced the Infectious Disease Prevention and Control Act to permit collection and sharing of the personal data by the government for the sole purpose of infectious disease control. And that was after much public debates around the sensitivity of sharing and collecting private data, but with public support, ultimately this legislative action occurred. I would like to conclude just with a few thoughts and lingering questions in South Korea as we speak. So upon reflecting, the principles of the importance of democratic principles was abundantly made clear throughout the epidemic response. For example, as demanded in transparency and risk communication, which also encouraged that active civil participation that could shape the public policies almost in real time, giving feedback through social media and other channels. And thirdly, Korea shows a relatively decentralized governance structure, which means subnational governments enjoy a fairly high level of decision-making power. In terms of equity, like everywhere else in the world, Korea also observed that the pandemic exposed and deepened, but not necessarily caused, the underlying economic inequalities. So in response to that, the government released a series of just-in-time emergency cash transfers. But the debate continues on as to, is that good enough for long-term response to really solve the root cause that underlies the economic inequality? So the government and the public are actively discussing long-term policies to address that. Lastly, on sustainability, is it feasible or even desirable to continually run on an emergency mode? And what does that prolonged sense of anxiety and fear do to our communities and social cohesion? And these are some of the questions that are lingering on. Thank you for your attention, and I look forward to discussing with you further.
All right, Hani, thank you very much. I want to introduce, we're going to move into the panel section now, and we'll be taking people's questions. So please send us your questions. Any question at all, our panel will be happy to deal with it. We're covering a lot of ground here, and we have quite a bit of time left, and certainly we're going to have a good discussion. Part of that discussion, I want to invite Deva Prasad. Deva is an assistant professor of law at the Indian Institute of Management. His current research includes business law, ethics, and governance with a focus on health and the environment. He has a Master's of Law from the National Law School of India University in Bangalore, and a PhD from the University of Juridical Sciences in Kolkata. And his recent publications include Kerala Model of Health and Governance, Learnings and the Way Forward. And Deva is joining us for the panel discussion. Deva, welcome to you.
Thank you.
All right, so let me just get this started while we're waiting for questions. And a couple of the things, the common themes to all of us, as I understood it, was the impact of a public healthcare system, consistent and transparent messaging across borders and states. In the case of India, do we have enough personnel deployed in the proper way? And should this be a national response, or should each region have its own autonomy during a pandemic? Also, public trust in the leadership, which speaks to transparency, and a number of other issues which we will get to. I'm just checking to make sure that I'm on the right page for receiving questions. Let me start with something that you just said, Hani, and that is the idea of, can we run in emergency mode and for how much longer? Could you expand on that a little more, please?
Yes, so this, I would just say it both from my own personal perspective with having all my family members, including my aging parents there, and also just from what I observed from the news reports in Korea. So during the first month or so, that the early stage of the epidemic, understandably, I think there was an acute sense of crisis just because of the sheer volume of uncertainties. None of us knew the full magnitude of what it was going to be. And that was effective in galvanizing public support. Now, almost 6 or 8 months into the pandemic, even the ones that do genuinely buy into or believe in the importance of the public health measures, they're just fatigued. And just because we don't know how much longer it's going to be, and I personally believe that the messaging from the South Korean government could be improved in a sense that this constant sense of, okay, it's just, we are in a crisis mode now, which can be resolved perhaps in the next couple of months. To put in that, I'm going to use the term false hope, but I don't mean that anybody intends to do that deliberately, but regardless, in the face of huge uncertainty, I think even to put a time limit to it, intentionally or not, I think is somewhat dishonest. And I think that has a negative effect because people are now hearing the news that, oh, the vaccine's going to roll out, but it's going to be rolled out maybe next spring, maybe next summer, maybe next fall. So this constant moving of the goalpost, that doesn't work. And I just wonder whether the message could be a little bit more nuanced to continue to get that public trust and support, because there are two sides to it, public support and trust. And I think to get that trust, that full transparency, including the extent of uncertainty, in my opinion, I think would be helpful. At least that's the perspective from Korea, but I would love to hear how it's been handled in Canada and in India.
Okay. Deva, let me invite you into the conversation now. What would be your answer to that? What's your perspective?
Thanks, Hani, for the outline on how Korea had looked into South Korea had looked into it. But I think if you look at from Kerala perspective, I won't extrapolate it into the total Indian perspective as such. But at least from the Kerala perspective, that is also a fact which we are also going through, because the fact that how much more time the emergency situation would be continued is a problem from both economic as well as political perspective also. That is actually looking into what kind of decision making will happen in the public health space. It is also creating a problem from the context where the health workers also are stretched in their respective roles. As you also correctly point out, the population is a big factor in the Kerala as well as Indian context. So that is where I think it is actually creating a major question relating to how long you can actually continue with this extra support regarding the public health and all. And moreover, there is an other issue regarding the community support, which was earlier seen in the context of how there was a community kitchen which came into picture for the people who are trying to migrate to their hometowns when the lockdown and other issues came into picture in India. That kind of systems are now eroding slowly because of the fact that the local self-governments and the local administrations are also cash trapped, or they are also facing the cash crunch or the economic crunch due to the prolonged measures that need to be taken. So quickly to respond, yes, even in Indian context, especially in the Kerala context, we are also the fatigue regarding how far this kind of measures can be continued is a problematic affair which we are also facing.
Suchithra?
Yeah. So the main issue, as far as to how far do we go in this emergency mode, is a critical question, and slowly the restrictions are slowly lifted. So we could also see that there is always this conflict of from when do we have this normalcy back, and what is this normalcy that we are talking about. So, as I've already pointed out, the usage of mask and social distancing is something that through law and legal regulations that the government is trying to enforce in that context. But of course, yes, it is always doubtful that how long do we look at? Is it health? Is it economy? Or is it both that we take into consideration? But public life is important, economy is also important. But where do we draw the line? That's the critical question, I believe.
Yeah, and Maureen, trust in government and transparency is crucial to this.
Well, I was lots to think about there. I was thinking of how it's too bad that in Canada, we have not had someone that we can look to for inspiration during this pandemic, someone to be inspirational and tell us, like I think the Prime Minister of New Zealand did for them, that we can beat this. During SARS, we didn't rely on politicians for that. We had a couple of public health figures, one of whom I eventually married, Don Lowe, and the other was Sheila Basrer, who did provide us with that day-to-day kind of tough talk about SARS. They always admitted what they didn't know, but they always told us what we should be doing, and they would tell us when it wasn't working. You know what I mean? And it wasn't coming from politicians with a stake in the economy and things. We don't have that this time. There isn't anybody that we're all looking to for this advice. The United States would have Anthony Fauci if the president had allowed him to be that person. So anyway, I'm a healthcare worker. Am I tired? You got to believe it. I'm tired. I'm frustrated too, but I'm not going to throw my hands up and wait for a vaccine. We've got to beat this curve back down again. We just can't just throw up our hands and say, I don't care if a bunch of old people die in the next 5-6 months.
Yeah, on that, if I may, there's an interesting development, at least that's being actively explored and public money being spent on in South Korea. So I think Maureen might have alluded to this. As we look at with the data to learn about the evolving picture for transmission dynamics, and if we can identify what age groups, which clusters drive the transmission in a very specific context. So what's going to be true in Toronto may not apply in New Brunswick, but I think certainly in South Korea, that's what they're looking at. So one thing that we have more of now than almost 6 or 8 months ago is more data. So what can we learn about the primary drivers of transmission that can guide us in terms of a little bit more tailored control strategy, so that it's not always like a total lockdown or total lifting. Yeah. As you mentioned, are schools equally contributing as a driver, as a hotspot, compared to, for example, churches? I mean, large religious gatherings in Korea at the beginning of the pandemic had a huge role. So we shouldn't look at all social gatherings just homogeneously. So that's one area that I think at least the South Korean government and actually the private sector are looking at.
I will invite everybody to jump in when you feel the desire to, or when you have something to say. You don't necessarily have to wait for me to invite you into the conversation, but just, following up on what you just had to say, Hani, I noted in your recent article that South Korea accelerated, for example, a molecular diagnostic test through the emergency use approval system, enabling this rapid deployment of large-scale testing very early on. Do our panelists, all of you, feel like we should have a national response with consistent messaging across borders and states, or do you feel like your separate state and province, in our case, Maureen, can handle the individual responsibility of making decisions for that particular province or region?
Okay, sorry. Let me take it from this. I do believe that region by region responses are necessary because, as you know, here in Ontario, in our far north, Thunder Bay, Sault Ste. Marie, they hardly have any cases. So why should they not be able to have small church gatherings or maybe a little bit of indoor dining? Why not? But you have to keep a really close eye on that and be ready to pounce if infections flare up. Look at Nunavut right now and how easy, that's a fly-in community. People couldn't get into those communities without coming in on a plane, and now they have an outbreak. So I just want to say this, where the federal government could have done better is what Hani talked about, and what you alluded to, Carole, is that widespread early rapid testing of even asymptomatic people. We have never got that right in, I don't think, any province in Canada. We just didn't have the infrastructure to get that ramped up. And 8 months later, I don't feel it's adequately been addressed. And that's where the federal government could step in. I think that you should be able to get a test, and we should be smart about who gets tested if we have to control how many tests we're doing. But we should have adopted more of a system like South Korea did from the start. I don't know what it's like in India for issues like that.
Deva?
Yes. So from the Indian perspective, I think it's too large a country to coordinate all the measures at the federal level. So I think it's important to look at more from a provincial level to take measures, because for example, in India also, I think the northeastern states didn't see much of COVID cases early on, and there was at that particular point of time, there was no major need for a complete lockdown across the country in those regions. Those measures could have been more provincially coordinated, and I think it is important. Obviously, there could be a federal committee or a federal measures or aspects of institution measures to look into, but it should be more decentralized towards the local level governance, because that has helped, especially in the Kerala model. The local self-government bodies were given more power to look at which all the areas need to be quarantined or be declared as areas which could be considered as some specific measures for restriction regarding travel and all could be done. That has helped to a certain extent. So that is where I think provincial and local governments should be given more power, especially in a country like India, where large geographical area is involved.
Suchithra, do you believe that there needs to be a realignment of responsibility between the federal and state and local levels?
Yes, so my article also points towards this in that context, because it talks about how different measures were adopted, but of course, because of the population, that is basically in terms of how, because of the larger population, just to add on as to what Deva had already mentioned, that because of the larger population, it might not be possible to have a uniform method, but of course, state responses or provincial responses are critical, and it is always the local or the government, the grassroots level worker or the government officials or the grassroots level workers should always be strengthened in that context to look at. So, of course, the immediate response of the different states of India is concerned, it is on this context of how can the numbers be reduced. Of course, quarantine and such other measures of isolation and so on and so forth were provided for. And of course, yes, from a legal background, what could be probably India invoked the 123-year-old Epidemic Act. It retrieved it itself to and it was clear that that was not something that was relevant for the information in the current scenario. But as far as state's response is concerned, of course, yes, I would like to compliment what Deva has said.
Yeah.
So this is interesting.
So what I'm hearing from people, and correct me if I'm wrong, is that it's not necessarily the best thing to leave all decisions at the federal level, but there has to be a certain amount of leadership from the federal level.
Right. Okay. And Carole, let me just say too, though, I worry what we've seen here lately in Ontario is the devolution of decisions from the province to local medical officers of health to make the tough decisions that are going to be politically tough. So businesses are no question, they're in trouble. Restaurants are in trouble. Even if they allow people inside, no one's going. So now the province wants to leave it to the local medical officers of health to decide whether those are open or closed. Well, the Premier knows well that come election time, businesses that go under are going to blame the person who made the decision to close them and to not allow gatherings inside. And so I worry about that as well. So like you said, there needs to be the guidance, the leadership has to come from the top down. But yes, you have to be able to pivot regionally in quick time to respond to what's happening. Politically, this is all going, that's why I keep emphasizing that a lockdown isn't really bad politically. I think, Hani, maybe you can talk about this, but how popular is the current government given how strict they've been with enforcement of the rules?
Yeah, no, that's a great point. I mean, to be fair, Korea hasn't gone through a complete lockdown. It has always danced around with various levels of 4 levels of restrictions to really minimize where you have to have total lockdown. So Korea didn't have to do a total lockdown, but I couldn't agree more with the point that Maureen said. I think maybe the way that we look at devolution of powers, it's not so much an either or of centralized versus decentralized model, but there are certain things that have to occur early on at the national government's level that serves the country very well. So I think if I think about how that decision-making power is distributed in Korea during the COVID response, the norm setting, for example, standard operating procedure for testing protocol, assay, case definition, and testing criteria, once the norms are set, led by the technical lead, not the politicians, the Korean CDC, then they're rapidly then devolved into the subnational governments. Then they can refine it to reflect the unique characteristics of their communities. So I think perhaps what helped the Korean public well was sort of to discern what role should the national government serve and then step out and then delegate to the subnational governments so that process itself is rational. But I want to emphasize that Korea really benefited a lot from the lessons learned from the MERS outbreak because it was horrible. The failed response at every level, national, subnational level. KCDC was completely emaciated. They couldn't react because it had been gutted with funds, and then all of that was sort of restored at the end of the previous administration, which is why sort of the basic coordinating mechanism was in place, unlike what Korea had at the start of the MERS outbreak. So I'm just very curious to hear to Carole and Maureen, since Canada also has experienced SARS, how did those lessons translate?
Oh, there were lots of royal commissions after SARS. Lots of, let's look back and what are the lessons learned. And I think there were 4 different reports, and there were creations of new agencies, like the Public Health Agency of Canada that we have now was a creation of SARS, and our provincial Public Health Agency of Ontario is a creation of SARS. But I can tell you that in time, that's 17, 18 years ago now, SARS. Memories faded, budgets shrunk, governments went back and cut again, and to my chagrin, and I'm glad my husband's gone and not here to see the lab system that he had built provincially after SARS, it was decimated, and we were left without enough nasal pharyngeal swabs. We were taking them from cervical swabs for gonorrhea. We were trying to use those. We were just totally caught off guard, and we didn't learn the lessons from SARS. We learned them at first, and then other priorities got in the way. And it's sad. And there will be more commissions after this pandemic, I'm sure.
Yeah, there is virtually everyone in the world, with the exception of the Atlantic provinces, and congratulations to them, and very few other places in the world. Even South Korea's leadership saying they're seeing triple-digit jumps, calling it a crisis, bringing in tougher distancing measures. I mean, their number in South Korea, are much lower than what we're facing in Canada and what you're facing in Carole. In other places in the world. What needs to happen? If I could ask you what you think the gap is now between the beginning of this pandemic, when we thought it was under control, and now it's making, the possibility of a third wave, and we're in a much worse second wave in many places. What needs to happen to get it under control now? Suchithra, let me start with you.
Yeah, so I believe it is significant that people are educated that this is the way in which that needs to work out. Because of course, yes, as far as masks, the usage of masks and such other measures are concerned, that is significant. And the transparency in terms of communicating with the public is significant. These are the 2 important measures that I would believe that is required from the state or from the officials.
Okay. Maureen?
COVID fatigue is real, and I think what is needed here in Canada is for us to come together and say that it is not over yet. Yes, these vaccines look promising, but they're not going to be in everyone's arms in the next 6 months. And so we have to do something together. And I think we have to reach out especially differently to racialized communities. I don't know if Suchithra and Deva are aware, but we have a particular problem in the areas of Toronto with Southeast Asian communities. And I feel, those are the patients I'm seeing, I feel that there are lots of reasons for that. They are our frontline healthcare, or frontline workers in everything. They're the ones who move essential goods around, and our nurses and other frontline workers. So we need to reach them in different ways, and we need to reach young people in different ways. Young people aren't following me on Twitter. I can guarantee that. We need to use TikTok. We need to use celebrities that they follow on Instagram to help get the message across. And we have to come together and say, let's do this one more time, and let's do it right this time. And that's why I know it's aspirational. We will never get to zero, but we have to aim for that in order to wake everybody up.
Yeah. Explain a little bit more for our audience what COVID zero is, Maureen.
Right. So COVID zero is a movement that was just started by some infectious disease physicians and epidemiologists in Canada over the last 2 weeks, because what they've seen is a bungling of the second wave by all of the provinces except for the Atlantic provinces. And we know doing working, this idea of a balanced approach. Let's keep the economy going and let's try to protect the vulnerable. It's not working. And so what they're saying is, screw it. We may not be an island like Australia, New Zealand, but we can try to aspire to COVID zero approach. And we're going to have to go back into some sort of lockdown, but we see a light at the end of the tunnel, and it doesn't have to be everything. Schools might be able to remain open. Maybe some businesses can still remain open with distancing. We, as Hani said earlier, we have data now and experience, and we can do this smart, but we've got to take, that's what COVID zero is. We have to be aspirational about this.
Okay. Deva, on the issue, and Hani, I know you've written about this as well and spoken about this. You talked about it a little bit earlier, but Deva, I wanted to ask you about what are you seeing in terms of social inequality and in terms of work when it comes to COVID-19?
Yes, that's a major factor which I think is weighing in on the Indian decision making regarding COVID-related issues. What is a major problem is seen as that the migrant workers or the laborers who are working in the infrastructure sector, they actually suddenly found that there was no work being happening because the quick lockdown which was announced across the nation. Then came the issue where most of the in India we have this unique problem of daily wage workers who would be occasionally getting work but may not actually be completely engaged throughout the year or the entire period they may actually be ad hoc workers at maximum, we can say. Those workers actually found that they are not able to recoup in this kind of situation, and only way that could be looked into is that states or government have to go and support them. Obviously, government have issued measures for them. At least there has been certain attempt to actually provide them with certain food items or actually shelter homes facilities. But the issue obviously is that inequality is so huge, or the issue of human rights is so huge in India with the population factor. It is still a factor which is affecting the people who are not within a formal workspace.
Okay, we have some questions from the audience. First one is, thank you for all perspectives. Given the problems we see in having effective national responses to COVID-19 in some countries, what is the future role and need for non-political, non-government actors, such as the Bill and Melinda Gates Foundation, to advance the discussion of public good? Hani, I'll start with you on that one. I know you're not here in this capacity, but you do have a relationship with that organization.
Yes, so I'm going to respond to maybe just the role of civil society organizations at large. I do want to make a careful distinction between civil society organizations and a very large private philanthropy, which the Gates Foundation is. And I think that distinction is an important one. So for civil society organizations, at least in terms of the context that I'm familiar with, which is Korea, this is hugely important. Why? Even as we see in responding to the government announcements and communications and policy formulations, there was truly like a real-time feedback through this organized civil society groups. To point out that we don't feel comfortable about giving up so much rights in terms of like right to assembly for religious gatherings. Where are your data to show that the religious gatherings are the hotspots? And I think that's precisely what's needed from civil society organizations, because they're not tied to a particular political party. They demand greater data, they demand more rigor. So the government has to respond. And I think that role has to continue to come from diverse, small and large civil society organizations. That's a slightly different question from asking that what should a large private philanthropy do? And that perhaps, I don't know if I have lot of time. I think that we should approach a little bit more cautiously, because unlike small or medium civil society organizations, a large philanthropy, its decisions, actions or inactions, both can have unintended consequences just because of its sheer presence and size. It has the unintended consequence of distorting priorities even when it doesn't intend to. And it certainly doesn't have the democratic representation. So I think that answering that question might require a little bit more time, but.
Okay, we'll leave it there for now. Our next question is with respect to building public trust and transparency, both to increase compliance with public health measures, but also to induce resilience into the public as the pandemic drags on. Where do you see science communication fitting? In Korea, we see experts as opposed to politicians being in charge of risk communication to the public. In Canada, it's the opposite and has caused frustration in both the scientific community and the public. Maureen, we've heard from you on this, and I'm going to come back to you in a moment, but let me get a sense from Deva and Suchithra. What is the mode of communication in Kerala state, for example? Suchithra, you first.
Yeah. So as I had already mentioned, so in terms of the health, or like, you know, if you look at how probably the communication channel is, of course there is the press is being addressed by the political members, but they're also briefed by the health, like, you know, the doctors and such other health workers who are in the front line. And also it is significant to note that the health officials are provided with the assistance that is required. So this support is from the government. Of course, the hierarchy in terms of communication remains with the politicians. But we do understand that there is the health workers are provided with the support, and we have also seen that how probably the even, like, you know, the communication channels are, of course, that is open. Of course, the social medias and such other platforms are used. But this is the gist of how the communication process is. And there are other channels such as, like, you know, the social medias, and also the old systems of, like, you know, usage of loudspeakers in and around a particular community. So we also have, like, you know, the groundwork that happens. So different modes of communications are used. And it is also significant to note that the support that is provided, so the government and the health officials go hand in hand. So that is something that is significant to note.
Maureen?
I think this question, the questioner has nailed it. As a former journalist, it is, and somebody who is doing research into COVID treatments and things, so I consider myself somewhat of a scientist. This is the most frustrating thing, and so different from SARS, where the politicians have decided that they're going to be out front and center every day answering media questions. I'm always too busy to see those daily media briefings, but I happened to see it on Monday as I was waiting for my COVID test to come back negative. And anyway, I was struck at how the reporter, they are on the phone, right? Because they're not allowed to be there in person, even socially distanced, and they're allowed one question and one follow-up. And apparently it's the Ministry of Health and the Premier's office who are selecting which journalists get to ask questions. So often there are tons of journalists on that call who never get their question in. During SARS, we went down to this auditorium. We had a dais of, you know, there might be one politician there, but mostly it was scientists. And we asked them tough questions every day, and they couldn't get out of it because we looked them in the eye. But thank God for shows like the one Carole hosts every night on CBC, because the media at least is stepping in other ways to bring those science experts to the public, allowed to ask questions. So you almost have a dual track here going on. You're getting hopefully the information from scientists who don't always agree, by the way, but that's good. And then you've got accountability with the government who are making the decisions, and I'm afraid that that one's not so great at the moment. So that's my view.
Hani?
I'll just add one thing. So I strongly agree. So in the case of South Korea, for example, the daily briefings, the politicians were nearly absent. You see the leader, the head of the Korean Center for Disease Control, updating not just the figures, but explaining what is meant by reproduction number. So when it goes up from 0.5 to 4, that means one person will spread it to, every person will spread it 4. And there is a double track going on because the media will then pick up on that theme and invite other scientists, infectious disease specialists, to explain that, what is the reproduction number and how does that help us predict transmission. So that when the government announces that we need to increase the social restriction measures because the reproduction number has jumped from X to Y, public, I think, understands that, okay, this is not some hoax. There are actually data that can convince us why it's a certainty that this current case count will rise at a certain rate. That public trust and the emphasis on science and hard data, I think that was hugely helpful in Korea.
Yeah. Deva, what's your perspective on this and the dissemination of information from politicians versus scientists?
Right. I think, as pointed out in the Indian context, it was obviously the politicians who were trying to come out with the daily media briefings. But I feel in India, at least in Kerala, it has worked out because the chief minister, that is the highest elected person on the state, actually giving clear warnings, and he interestingly was backed by the medical team or the medical chief medical officer plus the health minister of the state to help out with relating to data. That is something has interestingly helped out in bringing the early on what you call as leadership drive at the state level. But one more thing which I think is very interestingly unique is because social media being used by all the health workers at the local level also. So I think that has given more impact, and I have seen people using Facebook and other media channels or WhatsApp groups. That's something which has been used for local communication, has been used much for this kind of information dissemination. So that has played a major role, apart from the information dissemination coming from the political leadership. And just to add on quickly, yes, media had played an important role, visual media with help of bringing the doctors as well as health experts. But of late, I've seen that the emphasis has gone out because there is an understanding that they feel that the epidemic is almost on the way out. But I think that is a wrong step happening in the Indian context because media is slightly deviating the attention now. Hopefully it comes back.
Yeah. All right, we have about 5 minutes left. So why don't I get your closing remarks now? And let me begin in the order that we started with. So Maureen, I'll begin with you.
Well, I just want to say that it's been very enlightening to hear about the experiences in other parts of the world. We tend to get such tunnel vision here in Canada. I don't think the world will be the same after COVID. I think that this has affected everyone from the upper echelons of society, including the royal family in England, right down to the homeless people and people with drug addictions that I still have to see in hospital. I mean, I do see things other than COVID. I'm in the twilight of my career as a physician assistant. I had planned to retire before COVID. I was going to do it in the next year or so, and now I'm putting that off. I can't even imagine not being there for my colleagues who are so exhausted. So I'm going to hang in, and I think that I'll never again be able to have that kind of face-to-face interaction with patients that I so loved. They don't know what I look like from here to here with my mask and my shield. And I think that will become the norm because we don't know how well the vaccine is going to work over the next few years. I don't think COVID will just melt away. And so, yeah, that's what I want to say. I'm a little sad that I'll be going out on COVID rather than something more uplifting. I wish I could be more uplifting, but that's kind of my mindset these days.
All right. Suchithra, what would you, closing remarks?
Yeah, I would like to thank for this wonderful opportunity to educate myself on what's happening in terms of across the globe. But the significant aspect is, I believe that COVID is something that taught us a lesson to see and to reflect upon ourselves and to identify those aspects that are critical. We also realize that, as Maureen had already mentioned, that COVID fatigue is real, but what do we do to strengthen that system? I mean, what do we do to strengthen not only the patient, but also the people who surrounded, the family members, also the health workers. So if the doctor provides us the services, but it is also significant, the doctor also has a family. So it is their health that is also significant, and also the mental health. So so it is when we had the complete lockdown, we believe that the child needs to have a great atmosphere to develop its skill, or the right to development is a right as far as child is concerned. But we lock them in a compound, within the four walls, and we realize that development is required, be it a child, be it a doctor, be it a health worker, the mental health and health as far as the system is concerned, that is significant. So of course normalcy is yet questionable as to what is going to be the new normal, but of course it is significant that we take into consideration the health workers, and also we educate and we prepare the channels in such a manner that we communicate. Communication is the key. So these are a couple of things that I believe that are significant.
Deva, your final remark?
So my quick note is that, especially from the Indian experience, is that we should look at public health and public health spending more critically at the federal level, and to give more autonomy to the provincial level to actually take measures. But public health spending has to be a priority. That is my quick takeaway. Indian experience, I think that is something which I think Global South should also look at.
All right. And Hani?
I would like to emphasize, first of all, public investment absolutely needed to earn the public trust. And as we collectively make decisions on how to allocate that public investment, there has to be an intentional focus on equity. As Maureen pointed out, we are not in this all equally. So an intentional focus on equity.
All right. I want to thank you all so much for this very enlightening panel. And Hani Kim, thank you for organizing this panel. Very well done. I think people have learned a great deal. I will remind people at home, don't forget to tweet, or wherever you're watching from, don't forget to tweet at Science Policy, #CSPC 2020. Also, you'll receive a short survey. Please fill that out, as it will help make the CSPC better in the future. And any further questions you have can be emailed to Hani Kim, HANIKIM 584@gmail.com. Thank you all very much for making session 122, COVID-19 and Public Policies, a success.
Thank you.